All right. So the topic for today is let's talk retention, supporting people behind collaborative care. Oh, Verna. It's all right. We like the baby. So sweet. Um,
Multitasking grandbaby number five. Sorry.
oh my gosh. I love it. All right, so wanted to have a discussion today about retention. Um, because it's very relevant, wanting to think about it across kind of our entire collaborative care team. So we have a set of questions to kind of start us out with kind of what the landscape is and understanding our workforce, followed by like what is some action, a discussion around potential action steps that we could take to help with improving retention and providing and how we provide support to those on our collaborative care teams. So I'll put this up here, and we don't necessarily have to start at the beginning, but the questions to ponder, also feel free to veer away from these specifically, but the questions are: what attracts staff to become BHCMs or psychiatric consultants? What keeps people engaged in this work? What factors make clinicians consider leaving from your experience or what you've seen? And then what trends do you notice in turnover? I feel like there's a lot to talk about related to all of these prompts. So anyone want to dive in?
We did a project one time and we looked at retention related to implementation. And essentially, what we found is that if the implementation wasn't done well and like people didn't get significant caseloads or they were doing a lot of chasing for cases and there was no pop health, they were just depending on handoffs, that they didn't stay because it's like, why am I here? I have to chase patients. My role isn't clear. And a lot of times, and that was actually very much connected to that. So, like in my
Mhm.
spare time, that's actually something like to look at care managers who quit in the first 3 months, right? Like, what did the implementation have in common? Like, for our spare time research.
Oh, that's spare time. Yeah. Yeah. I think that's a really good point. That's not one that had popped into my head, but totally makes sense. And I've seen it in implementations where there's some, it's done really well and that team, sticks around and continues to hone their skills and become a pretty strong team. And then there's times implementations where the turnover happens pretty quickly. Um, and I think that's for a variety of reasons. Yeah, I think the implementation point that you make, where there isn't a clear understanding of kind of role, they're not, getting patients easily. All of that, the implementation aspects is a factor. And then I also think it's, fit, because I think if it's someone I definitely saw in my practice when people were kind of repurposed or came with a different job into the organization with a different job description, and then were asked to shift to doing this different way of providing care and seeing a lot more patients. And it wasn't always a good fit for everyone, and that was okay too. Um, but I think ideally that shift or that attrition would happen before it's implemented. So I think there's room definitely for, people to have a better understanding of what they're transitioning to. Because it is unfortunate when all the turnover happens post implementation and then kind of those training supports are no longer there necessarily. And then but you have a whole new team and that can be really, really hard. What other things do people see about related to turnover or what keeps people engaged? Or people that are kind of a good fit and naturally attracted to the role? for the BHCM side, I saw people who were attracted to that role being ones that really liked the learning aspect of it, the continuous learning and the collaboration with um, other disciplines and all of the learning that happens from their psychiatric consultant, um, really thriving on that.
On that note, Annie, I think it has a lot to do with personality. If you
Yeah.
have salty therapist that's been in private practice for decades, and Verna's
Yeah.
laughing. You know, that they want to do no less than an hour session. You know,
Yeah.
it's difficult to change that personality versus someone that's wanting to work in a team setting collaboratively. Let's figure it out. You do this, I do that. In that approach is very different. And
It really is. Yeah.
and on that note too, it leads to turnover because those types of clinicians are trying to shove a whole hour session into shorter interventions instead of reframing how they work, and they're going to burn out.
Yeah. Yep. Definitely. Yeah. Yeah. What did Ashley? You're here, Ashley. Hi. You
Hi.
mentioned something about like sinking like a potato. The folks that still continue to try to practice in a way that
Oh,
doesn't align with
yeah.
kind of larger caseloads and the brief visits, and it's really hard.
I think I said sinking like a sack of potatoes.
Yeah. Yeah.
I've seen it.
Yes, it's true. It's true. Yeah, you really have to be able to make that shift in modality and mindset and how you're documenting, how you're interacting with the patients. It's a lot of things to shift. So I think that's a really good point Daniela made about personality and flexibility. And I have seen people come from more traditional psychotherapy, but that wasn't necessarily where they thrived. And then this is a better fit, and others where it's not hasn't been a good transition. Any thoughts on psych consultants? What attracts people to become a psych consultant?
I can speak to that a little bit. I'm a behavioral health care manager, but work with a lot of psych consultants, and what they really like is that we have them being able to work from their home, and so they still go into clinic for other stuff, but then they work partially for us, and they like that flexibility. That's what a lot of them do, and
Sure.
they really love working with behavioral health care managers, and just love that interaction, having that information, and getting the recommendation. I don't know. In fact, all of our psychiatrists love the work, and they want to do more. So.
Yeah. Yeah, that's great.
Um,
I Go ahead,
uh,
Brenda. Oh, actually, sorry, that was you.
I was just gonna say, I think our psychiatric consultant is on, Dr. Marina Rosengren. So, um, I know for what I've seen is, so Dr. Rosengren loves to teach. And the ability to teach us, like the behavioral health care managers, the primary care providers, regarding psychiatry and nuances of medications, et cetera. I know that that's something that she really loves and we love about her.
Mhm.
Thank you, Ashley. I'll echo that. Kind of really enjoyed the teaching aspect with both behavioral healthcare managers, PCPs, but just I'm someone who likes to work really collaboratively. I always describe I do outpatient work too, kind of like therapeutic med management, and this sort of falls very similarly, where I don't have to do as much of the therapeutic part, but it like aligns well with my like philosophy of how I practice.
Mhm. Awesome. What if folks think about the factors that make clinicians consider leaving?
I think like lack of clarity of the role, or maybe just
Mhm.
onboarding that we kind of like fast forward through. So like in retrospect, I think we've lost some that were like, wow, we didn't really spend the time early on. We thought we could just jump right in, like, oh yeah, I know what it is to be a care manager. And then months later, they're like, what is this job? And we're like, oh, so I think investing that time on the front end is so
Mhm.
important. Yeah.
That's a good point. I agree.
I also think sometimes when we onboard people, I hear organizations telling them what collaborative care is not. And I think I like to spin it around and talk about like it is amazing to be a collaborative care clinician. Like you get to use all kinds of like I say the BTs, right? Like you get to use all of those different evidence-based interventions. You have a lot of flexibility to really see people at different cadences for different times. And so like it can be a lot of fun. And I think we don't spend enough time saying, you have all these wonderful skills in your tool belt. Like now you get to use them all the time, like when they're needed. Like you're not just in one box, you really have the flexibility. And I think getting people excited about it is really helpful when they start. And I'm always really surprised that I hear like an onboarding, well, it's not therapy and it's not this and it's like I can imagine starting off a role that way sometimes, you know.
Yeah, yeah. I like that, a more positive spin, because there are a lot of really great aspects. And I think speaking to it in that way will also attract those people who are excited about those pieces.
Well, I have things. I had to first look and make sure we weren't being recorded as I came off camera eating my lunch, but then I see Verna has a baby. So I will say, I think that there were times that I neglected to understand that my behavioral health care managers, some of them wanted upward mobility, like that wasn't their last stop. And so trying to figure out, even if I didn't have something already, like creating some way for workforce development in terms of upward mobility. But also, that sometimes meant giving these additional assignments that were for me to some of my employees that maybe were good with data. Like they wanted to see the data and could bring that to life in a certain way than maybe some of my other behavioral health care managers could. So kind of tapping into that as well, because I have seen people leave because they feel like they're not being challenged or there's no upward mobility for them. And then I'll say the second thing that I've seen is individuals leaving because their caseloads are what they feel like is unmanageable. And so sometimes and I say I'm talking about Monica, but sometimes because of lots of factors, I might say like, okay, caseload of 80 is what everyone needs to have without some consideration for some of the different contexts at each of the clinics. So whereas Annie maybe could have 80, Verna might only could have 72, and Ryan, maybe he could have 90. I wouldn't do that to you, Ryan, but maybe, right? Like, so just some of those little nuances that in the beginning, when I was first starting out, it was just coming up with a number, utilizing all the data and, performas and all of that, but then really needing to listen to my behavioral health care managers when they were starting to feel stressed out that their caseloads were too big to get to the bottom of what was really going on. Sometimes it was a too large caseload. Sometimes it was more retraining that needed to happen for a behavioral health care manager. But caseloads is something I often hear in addition to wanting upward mobility.
Thanks, Monica.
Oh, it made me think of when Monica, when you were talking about like getting to the bottom of what's going on. I remember for my PCBH clinicians years ago, there was an assessment. Some of you might remember it was like the PPAQ. It essentially was like a self-evaluation. Yeah, Werner shaking around. It was a self-evaluation you could do, or have your team do. And, they would get scores and see how fidelity to the model. It actually makes me think it would be helpful, and we haven't gotten to kind of solutions or what to do about when we uncover these factors. But I wonder if there's one out there for behavioral health care managers that's similar to that. I think I've looked for one and haven't found one, but it may be you know, because someone's view of their caseload size, right, could be different than ours for various reasons of what's going on in their lives. And it's not necessarily about the number, but rather they're documenting too much, or they're, you know, spending too much time on this aspect of the role when they should be focusing on this, right? So just a thought, self-assessment can be a helpful tool.
I would share too, we lost a few care managers over the years with turnover to salary. Like we're a hospital nonprofit, so we have and it's completely out of, like, I have no say, or I don't even know the rate. Like that's how siloed we are with HR with what is their pay. Someone else decides that. So like they've been like, hey, I have this private practice job where I make X amount per hour and we can't match that. And we've lost a few to that. I guess our flip side to that is we like to say, well, it's continuity, it's, you know, consistent pay, even if you have no shows, and that may not be the case in private practice. And as a hospital employer, there's, you know, benefits with insurance and retirement and blah, blah, blah. But that's been one where we've lost a few people too, is, hey, we just don't pay competitively in this market.
I can give, and I joined late, so sorry, but Verna, look at how cute that baby, I like seeing you feed the baby. Adorable. Is that, we've had some turnover, of people who feel frustrated with, sometimes like patient, he loves collaborative kids, that's so cute. Sometimes patients who are like, you know, not super engaged, or like very challenging to engage. So like they get referred, the team works to engage them. They might be engaged for a little while and then they sort of peter out, and then they see the PCP again and get re-referred. And, you know, like I think sometimes there's just some frustration. And the other thing is also like, and I think this happened a lot with COVID and lockdown, is that a lot of people left. I'm also at a hospital, not-for-profit hospital. A lot of people left for, you know, like private practice and things where they can make more money in general and have more control.
And Monica, you put in the chat, love to hear what other perks people offer when the pay isn't quite there.
I mean,
or
I'm
even
not
if not at your organization, maybe where you were before, what perks did you
Sure.
maybe get? Because I think we all have probably been in a place where like, am I really getting market value for my awesomeness? Probably not. And so are there perks and where you are? Like, what are y'all offering? Just wondering.
Yeah, I mean, I'm not a social worker, but our LCSW, some of them came from the hospital inpatient side, and they shared that they have better work-life balance with this role because it's 8 to 5 outpatient hours. You know, in the hospital, they would work evenings or weekends for like case management stuff. So a few of them commented like, oh, this is so much better than working weekends with young kids, you know, in the hospital setting. I'm, you know, business hours on weekdays, so my evenings and weekends are free. So I don't know if that's something to play up for certain folks, is just that, you know, hours and work-life balance. So
I'm going to pop in here real quick. I'm Beth. I'm with CCNC in North Carolina, and there's multiple practices that I have helped over the past year with crafting some of their job descriptions, and I always encourage them to put on no on-call, and that really can be huge if they are a licensed clinician, if they've ever been in private practice, if they worked in agencies, to really highlight this is not an on-call position. And that I have found has been helpful for some of the practices for the behavioral health care managers if they're licensed clinicians that have been hiring.
Thanks, everyone. I moved us forward because I feel like we're moving into figuring out some strategies. So just some other question prompts to think about strategies. It sounds like this aligns with, you know, what strategies have minimal cost but could have a significant impact. I think helping maintain the licensure is usually not a huge like the licensure renewal is typically, for a BHCM is going to be probably under $200 a year, which is pretty low cost, but a significant help. CEs can definitely cost quite a bit more, but just as another potential offering that isn't, direct pay.
Yeah, and Daniela, you mentioned great opportunity to be a lead. So they can, right, like feel invested in the program, help with onboarding, they get shadowed, or even, yeah, being a part of the onboarding process for new
It's
care
it's a
managers.
double whammy because you make sure that your newbies are being trained well.
That's right. That's right. Bernie mentioned, yeah, providing clinical supervision for license advancement.
And I like what Christina shared about just the flexibility and an ability to manage their own schedules. I think that's pretty huge. Not every collaborative care program has that, but I think when it does, it can be a retention feature for folks.
I just wanted to put out to the group, we've developed a national sort of research group and we're collecting information now. People have seen the surveys go, and I'm wondering if people are interested, if there's an opportunity to say, what would the things we would want to know across organizations? Like, what is your turnover rate? What benefits do you offer? What things, so that we could actually come back and say, well, this makes a big difference. This doesn't seem to make as much of a difference, to sort of guide like what might be a good investment, or what were the caseloads, or do we track reasons for leaving? Like, not long, but something short. And then I have some doctoral research students and they can actually do that analysis. And because it's like de-identified easy data, it's something we could do. So if people are interested in that, then maybe that's something that, could be up for discussion.
I think there would be a lot of interest in that. Yeah, when Andy and I were, it was interesting. We were talking about, putting this agenda together, the idea of, okay, well, what metrics should we be monitoring to evaluate retention success? I know certainly for us, for our CoCM program, right, we track like billable percentage, like number of patients billed for, like caseload number, number of graduations, number of, refer out to specialty, those type of things. And was just curious, yeah, folks' thoughts around like what metrics really should we be monitoring to know, for retention success. Annual wellness, oh yeah. Amani, yeah, that's annual wellness tech emergency childcare stipend, yeah. Oh, Daniela, you get 3 CEU days and 1,000 to help cover CEUs. We get 3 CEU days too at Hartford Healthcare, and then 750. Yeah, and Monica, professional, yeah, covering professional membership. Stipends to cover costs of training or books. A lot of that has to do with, right, like growth and learning.
I know that when I was with Providence, we had a stipend, I think it was 2,000 a year per person for CE credits and trainings, but it was really open to whatever they wanted to do. So that kind of I was surprised that I expected it to have requirements around what types of trainings they were taking, where it could be directly applicable to the work that they were doing. And then when I went to our leadership, they were like, no, this is strictly for their own professional growth. And if they want to take something that's like that isn't necessarily applicable to the work they're doing here, that is their choice. And that I thought was quite interesting. But I was just curious if there's more guidelines or kind of permission tracks for different trainings, or if it's kind of any fair game for whatever people are interested in.
That's really cool, Annie. For us, it has to be applicable to their role or their work here. But I still think
Mhm.
it's pretty flexible. I mean, if they want to use it to pay towards a conference, that's them or online classes and or their fees for renewals and stuff. So it's flexible, but it should be applicable for their work in this
Yeah,
setting. Yeah. That's really cool.
yeah. How about if we had money to invest in retention? Any thoughts on that last bullet around what should priorities be?
Hi, Monty.
Hey, sorry, my computer was giving me some issues, but hello everyone. I would say training and onboarding would be the biggest priority. I notice because when there is a lot of turnover, as a behavioral health care manager myself, when there's a lot of turnover, it doesn't just end with like not having a BCM. A lot of their caseload then has to be transferred over to other BCMs, and so you can go from having a registry of 50 and now overnight I have 70 because maybe two people quit or something. So I would say training and onboarding as a priority.
Mhm.
Well said. Hi, Verna.
Hey, I'm wondering also, the research always shows that money isn't necessarily the most important driver always. And I'm wondering, we haven't talked about interoperability, and like a lot of care managers are still doing really double documentation between registries and EHRs. And I think that actually certainly is not something that enhances one's, you know, work life experience. And so, I just wanted to put it on the radar.
Yeah,
I
I
agree
think
with that.
a good point. Yeah. Not being able to kind of end your day at the end of the day because of the documentation demands. They had that for years. And it's really, really stressful. Ryan says they have their BHCMs in a higher pay grade than their PCBH clinicians, which helps with retention.
All right. Curious about that.
I
Yeah.
know. Do you want to share more
Oh,
about that?
sure.
Yeah.
Yeah. Yeah, no, it's obviously really helped out. And our case for that is that there's more work required, managing the caseload and everything that's required related to the therapeutic interventions, and then also the care management side of it. And just, yeah, psychiatric consultant, there's just a lot more than having a patient come in and see him for 50 minutes, then going. And nothing against that. I worked in that for a lot of years, but we were able to show that, yeah, there's more required.
Oh.
Mhm.
I would agree with you. I've done both roles, the BHC and the BHM.
Well, and on another note too with that, yeah, and moving from doing the 50-minute sessions as regular traditional psychotherapy, the big thing that got me to move over was being able to interact with the patient more and not just have to depend on them for coming back next time and forgetting what their goals are, just this, how we can just interact with the patient just on a frequent basis and how much better they get. We've got all the data that shows, how much better they get too. And so that's a big selling point alone, I feel like.
Well said.
As far as thinking about like trends, do people have, I feel like the focus has predominantly been on behavioral health care manager turnover. Do you have organizations notice turnover in psychiatric consultants? Does that one? I didn't necessarily in the organizations where I practiced, but just curious if that is occurring elsewhere and kind of the why for that.
Hi, Verna.
I did have one organization that I was working with in oncology that had a lot of turnover with their psych consultant. I don't think, in my kind of anecdotal thought process around this, I don't think it was because of the role of the psych consultant as much as it was they were looking for psychiatrists, and those psychiatrists had multiple jobs, right? And so then when the psychiatrist was deciding, I guess, what to keep and what to let go, and probably the financial pieces of it, they were on the chopping block. It happened to them like 2 times in a row. And I was just like, oh, goodness. And I didn't experience that in organizations where we were a larger organization and the site consultant was a part of our larger organization. So this was an oncology practice that was contracting out for site consultants. And so I definitely saw that there, where it was like, you're contracting out, which is fine, you could do, but then how many other jobs does that site consultant have, and their time and ability to do the things that's needed for collaborative care?
And Eric mentioned to build appreciation for CoCM and BHCM and showcasing CoCM outcomes and related health improvements to practice as a whole, building recognition, and help staff see value, and they work on what might seem like extra tasks. But yeah, I think that that is one of those key, that second bullet of that requires very minimal costs, but definitely really critical and important. I think when I worked as a BHCM, it was definitely easy to get into just the day-to-day nuances of providing the care, but to have someone else even be able to like show me a bigger picture and extract some data and what I accomplished, or how many patients I saw over the course of the year, or our whole program, and sharing that with the organization, I think is really helpful. I think we get kind of stuck in the grind and don't necessarily always look at those things. And the focus with collaborative care, you want to look at the patients that are improving, but there's also so much focus on those that are not, and helping adjust treatment so those people can reach targets. But I think, yeah, for certain personalities like myself, I needed someone else to more point out what we had accomplished as well, because my focus was elsewhere, and I think that helps. Imani?
Yeah, to you and Eric's point, one of the things that I had suggested for our organization is every Friday in the Slack, it says like weekly kudos, like who do you want to say kudos to or whatever. And so I suggested maybe turning that into like an appreciation for the BCMs, because so much of the work that we do doesn't really get recognized until the person like graduates. But if you can say something like, okay, Monica had 2 graduations this week, and then Annie had some patients that showed a 50% reduction in symptoms, like that really helps to feel recognized, and not that, it's all about just like the metrics and the data and and the patients that aren't getting better. But I find that that really helps with like the team building and building that culture, especially if you come from a program that's like strictly virtual or hybrid, where you're not always able to celebrate each other and work with each other. I think that's good to implement that.
Yeah, I agree. Where there's not those kind of like natural hallway conversations happening and
Right.
moments of appreciation. Yeah, that's a really good point. I was on an implementation call last week where the 2 PCB champions were both sharing just feedback they had heard from patients about how these patients really enjoyed working with that behavioral health care manager, and felt like it was the person that they didn't know they needed and in their life and right now. And just in that in itself, that type of feedback, I think, as well, the direct patient stories and the feedback that's coming back to those PCPs, but we don't always have like the structure or the venue to share that type of information. I think that can be really nice as well. So if there's opportunities to share kind of patient stories, but I always like to have a collaborative care, like a spot that was consistently on the agenda for like an all clinic wide, or some of those larger organizations, even if it's 5 or 10 minutes, where we could share either specific data about the care managers' caseloads and how many people they've seen in this past year and how many people reached response or remission, and or sharing of a story to kind of mix it up a little bit, but just to highlight what's happening in those programs, I think is nice. And so to have some standing agenda item where you're even, and then also throwing in like a reminder of referral criteria or whatever else messaging needs to happen. But I think a standing agenda item where there's a piece that highlights the successes is great. Jen.
I need some advice from you, smart implementation folks. How do you push back against pushback with that? My system, we've been doing collaborative care 8 years, and I'm getting pushback of, we don't need to add CoCM to the agenda. We get it. But then we hear care managers say things like, but the PCP is introducing it like, oh, we have a therapist down the hall. And I'm like, but I think we do need a refresher on the elevator pitch. How do you keep the good work going when you notice drift, but then the organization feels like, oh, we're not new, we're not implementing this, we're mid career, we're years in, we don't need to have a refresher. Like, I'm finding it surprising and frustrating that even in my own system, we're like, wait, we've been doing this a long time. That's like, nah, we don't need that. Anybody else ever handle that, or is that just my messed up system?
Your comment, Dr. Thomas, reminded me of a exercise that we did done with a couple of practices before, not necessarily CoCM, but integration, that whole, at large, and just quizzing everybody. And you could do this now with the QR code and, online Menti things, but this was done the old fashioned way with folded up pieces of paper. But like, what do we call this person? And they all put in their stuff, and everything was completely different. Why do we do this? Just various questions you can kind of think of about, nomenclature, outcomes, what's possible, and nobody was on the same page, including the providers. And so that, of course, generated more willingness to keep talking, because it's not all done. It's never all done. Nothing in primary care is all done. I would challenge them to tell me what is all done, other than, in this case, CoCM.
Yep, I agree. I don't know. I guess I'm finding I just have to keep being, I hate to say pushy, but you feel like you're being pushy. Like, we don't need that. We don't have time for that. Again, I get it. I'm medical. Like, I'm not you guys. I'm not a BHCM. I'm not a psych consultant. I'm the PCP side. We're like, I understand how busy they are, and the agendas are stacked with immunization updates and blah, blah, blah. Like, I get it. But integration and CoCM is part of routine care too, if we do it right. So like, it does deserve even a 60-second blurb in the meeting, right? So I don't know, I guess that's just me talking to myself saying don't quit, because it's like, it's hard when you receive that feedback from like the higher ups you work with for years. They're like, no, we're not doing that anymore. It's like, ouch, that sucks. So
I say don't quit, Jen. Don't quit. I'm going to say that though. I think it's important to still highlight, even if it's not like the data, like something, right? Like the providers, the rest of the team, like people want to know like what they're doing matters. So if nothing else, there should be opportunity to highlight the data. And it doesn't necessarily have to be separate collaborative care, but wherever we're talking about A1Cs and everybody's A1C, right? Like we talk about that all the time. There's these other metrics that we have. I'd also say I think it's really important to make sure that collaborative care is a part of the onboarding. That's where I see things fall short a lot. And we do have a lot of turnover in healthcare in general, from nurses to providers to like just the whole nine. And so, how are we making sure that collaborative care is in the contract and the providers know that that's a part of what they're taking on when they come to the clinic? Some of those pieces I think are important for onboarding.
Yeah. Thank you. I appreciate the don't quit, because selfishly, it's been hard in my shop, because like I'm our PCP champion turned medical director is like the quote title, but I don't have a formal job description. It's literally not on the org chart. So when I try to assert like, hey, this is how collaborative care is done by listening and reading and learning from you smart people, I think drift is the word I'm describing, because we have a BH lead who's got very good intentions, but has a lot of experience in like a PHP, like eating disorder clinic. And even she is the lead, sometimes a lot lately pushes back against the weekly SCR, for example. Like in our shop, we mainly do adults, but we have family medicine clinics. So each care manager has a handful of kids. They consult with a different child psychiatrist. And literally yesterday, I'm like, well, why should we meet with her every week? We have 2 kids. What changes week to week? Or, well, the parents don't want meds. We don't need to meet with the psych consultant. I'm like, but it's pop health, it's collaborative care. And it's so hard when like you're trying to be collaborative with your teammates and yet also, like Monica, we were talking last week, right, with like rubber fence, like the model, like there are parts of the model that are sacred, like you need to meet every week. And it's hard when you're like trying to voice that with like culture war of like private practice, like usual care seeping into like what's proper with CoCM. I'm just complaining. I'm on a tangent. So anybody ever have pushback with that? With like, why do we have to have the weekly SCR? That's been my frustration this week.
Yeah.
What's that? Annie, teach me how to talk to, because I'm not you. Like
they would cancel it. They would cancel it.
Yeah,
and
so what do you do?
Therapeutically, it is not an option to cancel
Okay.
it. There is
Okay.
someone to talk about. Always. There's
Okay.
always someone
Even
to
if it's
talk
one
about.
kid.
And it's also
Yeah.
not just up to the BHCM. The psych consultant might have someone they want to follow up on. So it was usually on the side of the BHCM and they would cancel it. And that's just not not works. But it can also be an opportunity for education.
Even as a physician saying, hey, you meet every week. That's the right way to do it, right? Am I not okay? Because I feel like I'm going crazy. I'm like, no, the Monicas and the Annies of the world say like, hey, this is a good idea. Like, trust them. They've done this a long time. Okay, well, I will keep drumming that drum.
And like the recommendations related to pediatrics might not be medications, but they're still very important recommendations. Discussions that happen across those roles. So, and that's okay if it's not meds. That it's frequent that those conversations are a bit different and the recommendations are a bit different and often outside of the med realm for peds. So that's
I wonder too, for like the physician engagement pieces, if like leveraging providers against their colleagues, for lack of better terminology, would be helpful to like highlight providers that are doing it right, or try to get like a champion to kind of be the spokesperson. Or if you're looking at data, like say, hey, we got, X provider had the most new referrals this week, or, such and such providers has X% of their patients that are getting collaborative care getting better, or, whatever. And not to make it a competition, but to really kind of maybe highlight if there are discrepancies, because I know we see practices where like some providers just don't refer at all, and some providers are like really engaged, and then maybe those providers that are really engaged can kind of speak to what benefits they find of it, or if they kind of were a hard sell, like what turned them around, or even like if you're not doing data, feature like specific patient cases, like, hey, I had one of Dr. Smith's patients this week that has had a persistently high A1C, and they've been in collaborative care for the last 3 months, and like their A1C went down for the first time in 2 years, and their depression score has improved, and they're being more compliant. Like, also try to leverage some of the things that may be more sensitive to measures on the physical health side that they care about. That could be something too.
Yeah, I kind of have two thoughts. One of the things that we've noticed is that we sometimes get referrals for patients who think that this is therapy and get upset that it's the med management. So kind of highlighting that piece. That part of it is reminding patients, because like sometimes they're getting the wrong referrals. It's taking up behavioral healthcare manager times and intake slots, which kind of slows the whole process down. Like our program, we're kind of waiting a while, like longer than we would like for intakes. And so kind of being able to monitor that might be kind of something like rooted in that this is impacting like patient care and the bottom line, that might help you give a space to kind of speak up. But I also say kind of reaching out to, I don't know what your relationship with your consultant psychiatrist is, but I definitely have PCPs who reach out to me kind of directly. And if there is an issue with med management, or if, I think the behavioral healthcare manager needs to like maybe reach out in the next week or so, like I'll definitely CC them on to the response. But I have a pretty open dialogue through like Epic chats and Tiger texts with all of my PCPs, some use it more than others. But, you know, if you do have any concerns of things, you know, you don't have to like throw them around the bus, but like things to think about, you know, I would definitely would like to know if, you know, any of the PCPs had concerns about what a patient was being led to believe, or behaviors or medications were being dismissed or things like that. So I would say always, you know, again, I don't know what your team is like, but I would love to have been kept in the loop as kind of a psychiatric consultant if PCPs had any concerns.
Awesome. Thank you. That's super helpful. I think we're on the right track. I think what we're speaking to is we had a legacy of like a not great psych consultant that was, I think, I know didn't do the onboarding that we asked, and it was like, oh, just call me if you need me. And then really quickly, the PEDS CoCM work turned into a very co-located, very few touch points with the psychiatrist. We were not doing registry. It was not CoCM. So we had to like completely kind of shut it down, and we're just now restarting it. So I guess if my frustration comes out, it's just because I really want us to, now we have a new psych consultant on PEDS to like, hey, let's get in some good habits. There's things like a weekly SCR that's good, and looking through that whole list. And even if you've got 1 or 2 kids, let's talk every week. Kids not doing bad, great. Well, let's talk about SSRIs, or, you know, something like just that importance of like building relationship too. So I think if anything, I appreciate all you validating some of the like, hey, I think we're on the right track with getting some better things going than just kind of like going back to the old way, because it didn't work. Like we kind of had to really gut it, and it was kind of a very bad drift situation where it was like, this is not collaborative care. So it's tough. That's the real world, right?
Yeah, I think model drift could be a good discussion topic for the future as well, because that happens and it really takes continuous effort to monitor and prevent that from happening. And you can't just see the program as something that's, you know, done and we don't need to look at it anymore. So it should have some continuous quality improvement, but also signs of drift, and also like signs of success and signs of growth and signs of stability to also watch for. So I think that could be a good discussion. All right. Well, I know people are jumping off to transition to their next meeting. So to give everyone a moment to grab a snack or go to the bathroom, I think we can go ahead and wrap up for today. But we will see you guys next month in August, already August. But thank you everyone for the discussion today. I appreciate it.
So much. Thanks for letting me bend your ear, y'all. You're very supportive.
Always, Jen.
Always. See you soon.
All right. Bye.
Thanks, everyone.
Thank you.